Well, welcome everybody and good afternoon. And my name's Dominic Tarpey. I'm going to introduce our speaker, but you're attending the Intensive Services Grand Rounds here in the Department of Psychiatry and Behavioral Sciences at the University of California, San Francisco. It's my pleasure to introduce Dr. Jeffrey Devido, who is Chief of Addiction Services for Marin County Health and Human Services. He's also the Behavioral Health Clinical Director for Partnership Health Plan of California. He's also on faculty here as a volunteer assistant clinical professor in our department. And his talk today is Understanding California's Medi-Cal Substance Use Disorder Treatment System. Additionally, just to introduce Jeff, Dr. Devido received his medical training at Columbia University College of Physicians and Surgeons and completed his psychiatric residency at Massachusetts General McLean Hospitals. He also completed a fellowship in addiction psychiatry through Harvard Medical School. In addition to that, he has a master's in divinity from Harvard. And I have worked with Jeff in the past, so I'm very pleased that he's with us today. We worked together here when he was on the psychiatric consultation and liaison service. So great background and experience. And what we'll do just with the chat, as we have done, I'm sure all of you have attended grand rounds and similar meetings, we will monitor the chat for questions. So feel free to put them in and then we will get to them as soon as we can. And Jeff, no further ado, I'll turn it over to you.
All right. Well, thank you. And it's great to be back. As the names were coming in, I was scrolling through. I recognized some names. It's good to see folks and see the names, and also to get reconnected because it has been a little while. It's been about 5 years, I think, since I was last walking the halls of Langley Porter and the rest of the hospital as a CL attending. But it's good to be back. And I thought of a great joke as Dom was introducing me because, trying to make the connection between sort of my background in divinity school and Medi-Cal, and understanding Medi-Cal, certainly I think there are many, many different jokes that I could tell in there in terms of what would be needed in terms of divine grace to be able to understand sort of the multiple dimensions of Medi-Cal. So with that being said, I kick it off with my real humdinger joke there, but let me advance here. So I have some disclosures, just standard disclosure stuff for me. I'm going to be talking about my own opinion and my own understanding and my own sort of perspective on the Medi-Cal system and how it relates to substance use disorders. I always put this up here. I do have equity shares in Altria and Philip Morris from an inheritance. Long story, but nonetheless, the nothing that I'm going to be talking about today is related to the products that those companies make. I have no other relevant financial disclosures, and I'm not talking about treatments here really today. I'm really talking about systems. So it's kind of a different kind of talk in some respects because it doesn't have heavy sort of treatment focus, which I'm sure a lot of the grand rounds talk a lot about. Different treatment approaches for folks, but I do have some objectives. Hopefully, I tried to keep the objectives fairly modest because I'll be completely honest. When it comes to Medicaid, when it comes to Medi-Cal, when it comes to Medicare, when it comes to any of the funding systems that we have in place for delivery of healthcare services, there are many, many much smarter people than me that have made their entire careers out of understanding and trying to understand sort of the complexities of these systems. So I'm going to try my best to keep us close to earth on this without getting too far into the weeds, but there are some points where things will get a little bit topsy-turvy, so bear with me. But I do want to make sure that folks at least have an understanding of the differences between drug Medi-Cal and drug Medi-Cal organized delivery system. I want to make sure that people can identify the differences between services provided by managed care plans and county mental health plans. Again, I don't expect people to memorize this and kind of have a fully nuanced understanding of this, but just a basic framework for understanding how the systems are put together. And then in order to do that, you're really going to have to, and I'll make the argument throughout the talk today that we're also looking at sort of like understanding the flows of money because the flow of money really does determine a lot about services and which services can be provided by whom and where. Not surprisingly, money is important. So, let's talk about Medicaid, everybody's favorite subject, right? So Medicaid is a topic that usually is one that is guaranteed to put most people to sleep. But I'm trying my best to kind of make it exciting today. I don't think there's any way that I can make it as as exciting as perhaps the Oscars were last night. But nonetheless, I'll do my best to try to make it relevant and interesting. So let's start with kind of talking about some history here. So we have to understand, and again, I'm making this argument that understanding the history, understanding the reason why things are connected in the way that they're connected helps give you a framework for understanding how these systems work. Because on the ground, when you're practicing, when you're working with individuals and you're trying to navigate a complex system, you're seeing this in real time. When the patient tells you or the client tells you, says, hey, I can't get to XYZ service, or their case manager or care coordinator says, no, they're not eligible for service there, they have to go over there. There are reasons for that. There's reasons that things are set up this way, and the background, I think, is helpful in that. So for starters, I want to take us way back to 1935. This was a time long before myself, long before Dom and everyone else on this call today. But nonetheless, 1935. This is the Social Security Act. So this is the creation of the Social Security program. Again, people have made their entire careers and dissertations out of studying Social Security, but there's a couple things that I think are worth mentioning about Social Security and why it's important when we're trying to put things in context with Medicaid. So for starters, Social Security kind of started the idea of partnerships between states and the federal government for financing and sharing costs for different kinds of social service programming, and in addition to that, also programming around healthcare. Now, with Social Security, when it initially started, the only sort of healthcare aspect of it was really related to sort of creating this private nursing home industry. And again, that's not the point of this particular talk, but the thing to kind of recognize is that with Social Security, you started to get the groundwork being laid for the collaboration between states and the funding collaboration between states and the federal government around services. So that kind of sets the ball in motion. So let's fast forward now. A lot of stuff happened between 1935 and 1965, but I'm going to jump us forward to 1965. This is when Medicaid and Medicare are born. Medicare, just in very basic terms, begins with Part A, which is the hospital benefit, and Part B, which is the medical services benefit. Then at the same time, you have Medicaid born at that same time. Medicaid in its initial form was really tied to provide services and really kind of safety net services to individuals who were getting cash assistance from the government. So poor enough to be receiving cash assistance. So that's kind of where it starts. That's kind of the genesis of Medicaid and Medicare. And they kind of started together, and then they diverged, and they continue to kind of cross paths every so often. But let's take Medicaid and also look at also some of the developments with Medicare. The general trend in time with both Medicare and Medicaid has been an expansion in services that are covered and an expansion in people that are covered by those programs. So even though people say, Medicare for all, and there are different ideas of sort of like how we're falling short of providing services for everyone, I think it is important to bear in mind that the general trend historically has been an expansion in services and an expansion in people who are eligible for the services provided by these programs. So fast forward to 1981, this was a big time development where there was the introduction of freedom of choice and community-based care waivers. This really jump-started and set in motion something I'm going to talk about in detail later, which is that the states are given some autonomy to develop programs for Medicaid in their states that are unique to their states. And you'll hear me come back to this time and time again, which is that California's Medicaid program is different than Oregon's Medicaid program, which is different than Washington's Medicaid program. A lot of that has to do with the fact, again, the history here was that the states were given increasing autonomy to be able to develop programming with Medicaid dollars that ended up being unique to their states. So at the same time in 1981 was the formation of managed care plans. Managed care plans being the administrators of the Medicaid benefit. The federal government said, CMS and Health and Human Services at the federal level said, you know what, states, we will let you develop managed care programs to manage the treatment of individuals that are under your umbrella. So they gave them authorization to develop these managed care plans. So one of my employers currently, the Partnership Health Plan of California, is one of these managed care plans, Medicaid managed care plans, which were authorized by law in 1981. What the managed care plans do, in essence, all managed care plans do, is they're given a certain pot of money that they then are able to use to then provide services for the individuals that are under their umbrella. And the way that the contracts usually work is that there's a suite of services, that a whole range of services that they're mandated to provide with that as a string tied to that pot of money. So anyway, federal government says, you know, you can build these organizations in relation to the delivery of Medicaid services. So then fast forward to the big one, which is in 2010, we've got the Affordable Care Act. And I'm gonna have several more slides about this, so I won't go into great detail about the Affordable Care Act, but the Affordable Care Act really changed the landscape of Medicaid pretty significantly across the board. It created the health insurance marketplace, both for private and for Medicaid insurance programs. It defined essential health benefits, which we'll talk about. It increased the age that individuals could stay with their parents' insurance programs to 26. It eliminated the exclusions for pre-existing conditions. It eliminated lifetime limits on services acquired through Medicaid. And most importantly, and I think what most people would agree is, well, I can't say most people would agree, what most people might agree with, in my opinion, is the real thing, the real sort of, those things are important, but the real thing that was kind of game changing from an access standpoint was that the Affordable Care Act increased the eligibility. So there was an income eligibility tied to Medicaid from its beginning. Remember, there was those that were on cash assistance. Well, that expanded in time. It got more sophisticated, and they talked about a number that's called the federal poverty level. And to be eligible for Medicaid, you had to be at a certain percentage of that federal poverty level. That, as that creeps up, as that limit creeps up, then more people are eligible, right? So if you increase the eligibility for Medicaid to 10,000% of the federal poverty limit, you're going to capture most people in the country. You might not capture Jeff Bezos and Mark Zuckerberg and whatnot, but nonetheless, as you increase the eligibility threshold, you're going to have more people that are eligible, and that's really what the ACA's big contribution was, in some respects, was to increase that eligibility federal poverty level up to an effective rate of 138% of the federal poverty level. So that added the opportunity for a lot more people to come on to Medi-Cal, or Medicaid, and I've jumped ahead a little bit to invoke the name of Medi-Cal. So here's something that I think is, I always say this in my talks, there's something that's really important. If I didn't think it was important, I probably wouldn't put a slide on it. But anyway, so here, this is me now dialoguing with myself on Zoom here. But the idea here is to understand the basic financial structure of Medicaid funding. So if you take on the right here, start on the right and say, okay, a Medicaid expenditure. So like someone goes to their doctor's office, someone receives a medication, somebody gets some service through Medicaid. that service is actually paid for by a combination of funding that's coming from a federal source and a state source. This is back to that thing that I mentioned before historically about Social Security and sort of that groundwork for being able to look and say, there's a financial collaboration between state and government. This is the fundamental financial relationship that defines Medicaid expenditures, which is that there's a state contribution and then there's a federal financial participation or match. Now, one might argue that, which is the match? Is the state matching the feds or the feds matching the state? Doesn't matter. I'm not going to kind of get caught up in that, but there's a federal contribution and a state contribution. And that those come together and form the Medicaid, the money that actually pays for the Medicaid expenditure. So let's take a little closer look then with that in mind at sort of the Affordable Care Act and some of the things that came about as a result of that. So you've got the essential health benefits. The next slide, I'm not going to talk about it here because I'm going to outline them in the next slide, but there's the essential health benefits where basically what the federal government said by passing the Affordable Care Act was that, here is an opportunity to expand Medicaid. Now, initially they said, we're going to mandate everybody to expand Medicaid. But what ended up happening in the, and believe me, I don't have all of this off the top of my head. I have some notes written down here to remind me. The National Federation of Independent Business versus Sebelius in June of 2012 was a court case that essentially said, yeah, you can't mandate states to expand, to adopt ACA, basically. You can't mandate them to do it, but nonetheless, a lot of states voluntarily opted in, and some states have opted to not go in. I think some of the ones that have not opted to go in, I'm not going to go through all of them, but like Tennessee, North Carolina, South Carolina, Texas, these are non-Medicaid expansion states. So ACA, new program comes in, a lot more people are now eligible for the benefits under the ACA. So because of that increase in the eligibility percentage of the federal poverty level, moving it up to 138% for all intents and purposes. So now what you've got then in any state that expanded Medicaid is you've got two populations. You've got the people that have always been eligible, and now you've got the newly eligible people. And in the newly eligible people, in order to entice states to do this, in the newly eligible people, for the first, I think it was like 5 or 10 years, the federal government said, we will actually pay 100%. We will match whatever you pay locally, we'll give you 100% of that back for these newly eligible people. And we'll see how that plays out in substance use treatment in California here in a little bit later in this talk. So not surprisingly, a lot of people gained eligibility. You can see the numbers here. And there were, again, some of these things that I've already mentioned in the previous slide in terms of what other things the ACA allowed to people to have access to. If you bought in, if you expanded Medicaid in your state, if you developed your, if you adhere to kind of all the pieces of the ACA, these are some of the things that your beneficiaries in your state would get access to. The last one here on the list, which I think is good to mention, is that there was attention paid to trying to finally enforce parity, and really trying to kind of look at making sure that within those essential health benefits, that the reimbursements and that the access were all done, on par with one another, which has always been a problem, right? That mental health services, for example, are always, have historically been under reimbursed relative to, medical or other services. But anyway, this was also built into the Affordable Care Act. So moving forward, again, I'm not going to go in great detail about this, but just to outline, these are the essential health benefits. The real sort of game changer for us in mental health or behavioral health more broadly is the inclusion of mental health and substance use disorder services, including behavioral health treatment. This is an essential health benefit. So if you're going to expand. If you're going to expand Medicaid in your state in response to ACA, you have to offer these, and you have to offer these with some attention paid to parity between the access and the reimbursement for these services. So anyway, that was kind of a real game changer part of the ACA. So let's take a look at sort of what's been the impact of this sort of, nationally. When we look nationally, just some bullet points about sort of what's happened with Medicaid. Certainly, in the last like 10 or 15 years since the advent of the Affordable Care Act, but numbers. So in 2020, 77.9 million people are covered. That's individuals from birth to age 65 when people become Medicare eligible, and then they shift into the Medicare system, which we'll touch on a little bit later. That represents a 44 increase in enrollment in Medicaid since 2013. Not surprisingly, that's about the time things started rolling with the ACA. So as of September of 21, 23% of Americans are covered by Medicaid. The highest number of individuals that are covered by Medicaid are in California. You can see the number there, over 10 million individuals in California that are covered by Medicaid. New Mexico, however, has the distinction of having the highest percentage of their population being covered by Medicaid at 34%. Medicaid is the nation's largest payer for addiction treatment services. Okay, that's sometimes a little known fact that it's huge. It's a huge player in the substance use treatment marketplace. And as I emphasized before, and I put in red here to kind of further emphasize it, is that each state is different. When each state has developed their Medicaid program, it has looked a little different based on sort of like what they've decided or things that they've decided to undertake locally. We'll talk in a minute about how California really took the reins when it comes to substance use services in relation to Medicaid expansion. But as a result, California's substance use services landscape looks a lot different than New York's, or a lot different than Massachusetts, because again, there's this ability that was built into Medicaid to allow the states to help formulate their own programs based on their own needs. Okay, so what about in California alone? So in California, we've got, this is, I think, sorry, I didn't put the year up here. I think this is 21 data, but about $105.2 billion total in expenditures in Medi-Cal, California's version of Medicaid. About 10% of that, or less than 10% of that, is spent on behavioral health. Nonetheless, I know I'm speaking to the, primarily, it sounds like a lot of mental health providers. That this would come as no shock to you that behavioral health is a leading cost driver in relation to all the different things that all the different costs that stem from individuals with behavioral health conditions, particularly untreated behavioral health conditions. So Medicaid covers about a third of all Californians currently, and a half of all kids in California. Okay, so where does the money go? This is one of my, I guess I could have done better on the colors. It's not the most attractive colors, but but nonetheless, it's a complex slide with a lot of acronyms that probably are not familiar to people. They were not familiar to me as a non-finance person, but let me just kind of outline this. So where does the money go? So when California spends on Medicaid, where does it go? So this is basically, I mean, there might be some outlier other areas that people who are much smarter than me would be able to kind of like highlight, but these are the basic buckets that Medicaid expenditures fall into in California. You've got your health plans, which represent the biggest chunk. They're 65%. These are the managed care, the Medicaid managed care programs like Partnership Health Plan that I work with. They constitute about 65% of that total $105 billion. Then you've got the county mental health plans. You've got school districts that can pull down Medicaid dollars for certain services. Community health centers, your FQHCs, can pull down Medicaid reimbursements. Departments of public health, hospitals, and then the regional centers. These all are buckets of money that the state doles out from its pot of Medicaid money. Now, this is where it gets complicated, and this is where you'd kind of need a PhD in finance to really kind of, understand this as far as I'm concerned. Maybe it's just me. How the money filters through this is important, because it will give you a clue as to why some things might seem to run more smoothly than other things. So let me point this out here. So county mental health plans, they seek money from Medicaid through a complex process. The claim for the service is done through something that's called a CPE. And the CPE, essentially, what it is it's sort of a way of tracking services provided that allows you to track these type of service by the minute that it was provided. And then once you've documented that, once you've performed the service, and then you submit that after the fact to the state and to the federal government to get reimbursement for that. That's different than like with the health plans, like I told you before, where they might get a lump sum of payment up front themselves. They've got the money, and then they're deciding how to dole it out. So the administrative burdens on the county mental health plans are pretty significant, because they have to document by the minute, by the service. Otherwise, their services will be denied. So it's sort of, CPE means that you're getting paid after the fact. In my non-financial guru mind, sort of CPE generally is you're getting paid after the fact, after you've claimed for services that you've provided based on some algorithm, which leaves you in the lurch, number one, and number two, leaves you vulnerable to potential denial. And there's a lot of administrative burden that goes with that. As opposed to some of these other plans, whether it's PPS or IGT. IGT is intergovernmental transfer. It's, just a fancy way of talking about sort of like areas of government transferring money back and forth to each other. PPS, again, it's sort of a payment for, it's called a prospective payment system. It's a method of reimbursement in which the payment is made on a predetermined fixed amount. So you get a certain amount, and then your payment is given off of that fixed amount that you got at the beginning. So anyway, I kind of wanted to put this up here to say, here are the buckets where the money goes, and different buckets have to claim the money in different ways. Some can get the money and then provide the service. Some have to provide the service and then justify reimbursement to the service back up the ladder. So anyway, again, understanding how the money flows, if nothing else, is somewhat interesting and mind-boggling at the same time. Okay, so in terms of behavioral health funding in California, I tried to break this down. Again, this might not be entirely comprehensive, but I tried to break it down into sort of the major buckets where money comes from to pay for services for behavioral health. Now, this is a mix of mental health and substance use, but in some instances, they overlap, that the same funding source can provide some services for substance use and some services for mental health services. But nonetheless, these are kind of the big buckets. This is where, like, if you're gonna pay, if you're a county, let's say, and you want to pay for, providing a service to a beneficiary in your county, these are where you can go to get your money. You can go to the state, starting in the middle. You can go to the state. You can go to the that combination of the state and the federal contribution, the sort of FFP model that I mentioned before. There are general funds, just local tax dollars, such as, that either the state has based on state taxes, or local taxes when it comes to county, like property taxes and things like that. That every county has a pot of money. It's called their general fund. The state has a pot of money. It's called general fund. You can access that for, discretionary things, but that's the same pot of money that builds roads. That's the same pot of money that mitigates flood risk, does public service projects and things like public works projects and stuff like that. There are, for substance use services in the counties, you have access to what are called these SABG, or Substance Abuse Block Grant grants that come from SAMHSA, that come from federal HHS, and are given to counties if they apply for it. And it's a chunk of money that has certain strings attached to it, but you can use it locally to pay for substance use services. Now, we're going to talk a little bit more about this in a second, but I'll highlight it here and then we'll come back to it, which is that prior to the ACA, a lot of the funding for substance use services came from these block grants, because not a lot of services were actually provided by Medi-Cal before the Medicaid expansion that happened with the ACA. So these SABG grants were kind of like one of the big components that funded the services. With the advent of the ACA and the ability to now claim dollars through a different channel, that opened up the SABG block grants to be spent on other things. So like in Marin County, we spend a lot of the SABG money on recovery housing, which again, you can't use Medicaid dollars per se to pay for recovery housing. But now we have this money that we can use to pay for it because it's been freed up by the ACA, offering another channel to claim money through Medicaid. Then there are these other three up at the top here. There's MHSA. This is the millionaire's tax, on 1% tax assessed on every income, state income of $1 million or greater. That was in 2004. And then we have these two realignments. So these are important to mention because you might have heard of these before, but realignment was actually one of the few things kind of aptly named in government. It realigned the responsibilities for provision of services from the state to the counties. So it's with realignment in 1991 that we start to now see the counties providing specialty mental health services. It's with realignment in 2011 that we start to see individuals moved out of state prisons and into county jails. Now, with the movement of responsibility, the trade-off was that the state said, well, you counties are now going to have to take on responsibility for specialty mental health for prisoners. With this, because we're shifting it to you, that responsibility will pay you. So these realignment, it becomes what people call like the realignment dollars. You have money that's resulting from the movement of responsibility of services from the state to the counties. So if people are still awake and with me, it's incredible because this is not the most riveting stuff, I will acknowledge. I see that Dom's still awake, so that's one that's positive there. So good. So what do we do with the money? So I mentioned before that prior to the ACA, there was a limited array of things that you could use Medicaid dollars for and get reimbursed from the state for providing them. This is it. So this is what we call the state plan or drug Medi-Cal, as opposed to what I'm going to talk about in the next slide, which is the drug Medi-Cal organized delivery system. But prior to the ACA, and still in existence in some counties that have not opted to do anything different, this is what you have access to in terms of Medicaid benefits for individuals in those counties. You have outpatient drug-free treatment, you have intensive outpatient treatment, you have residential substance use services for perinatal women only, and it's limited to facilities with no more than 16 beds. This is the old IMD exclusion. There, you can get naltrexone and you can get methadone. That's it. That's what drug Medi-Cal covers. That's the original sort of substance use benefit. Now, what happens is that with the advent of the ACA, states were given the opportunity to get creative and figure out, well, how can we provide better and greater services to people? Well, California was really on the leading edge of this in creating what's called the organized delivery system. Since California went live with this, there have been, I think, 20 some other states that have moved forward with similar kinds of plans. But why is this? So this is, sometimes you might hear people talk about an 1115 waiver. An 1115 waiver is a waiver that the federal government grants to the states that says, you want to be innovative, you want to pilot something new, we will let you do that. You apply to us, we will approve your plan. And if we approve your plan, then you've got a time frame during which you can develop your program and show us how it works. That's an 1115 waiver. So California said, you know what, we're going to go ahead and do that. We're going to create what we're going to call our organized delivery system. So already, because of the realignment, you had a lot of shifting of responsibilities onto counties. So the counties said, all right, well then if we're taking on greater responsibility and we have an opportunity to get reimbursed and offer greater services, we're going to create programs in our counties that basically are going to function like managed care plans for substance use services in each county. So it's the goal of the organized delivery system, which began in 2015, was to increase the number of people receiving effective SUD treatment by expanding services and reorganizing Medi-Cal's SUD delivery system. Essentially, counties become managed care providers for their residents' substance use treatment needs. And off to the right here, you can see the expanded services that were offered through, and are offered through the ODS. Case management, recovery services, physician consultation, partial hospitalization. The big one though, multiple levels of residential SUD treatment. This is now covered under the ODS system. And it's covered, we'll talk about this in a second, how it's covered, but it's covered in a way that is financially not onerous on the counties themselves. So you went from having basically only residential for pregnant women and perinatal women prior to organized delivery system, to post-organized delivery system, where you now have access to all different levels of residential substance use treatment. So some bullet points about the organized delivery system. 37 of the 58 counties in California have adopted it. There is, and I put this quote up here because it's a common quote. Well, if I have Medi-Cal, why can't I go anywhere? Like, if I have Medi-Cal in San Francisco, why can't I go, over to, Placer County, where they've got a great, substance use treatment program that's Medi-Cal certified? Like, why can't I just go over there? Well, it's because the counties are managed care programs for their substance use benefit. If that treatment facility in Placer County is not contracted as part of the managed care of San Francisco, then that beneficiary can't go over to that. In other words, it's not portable from county to county. That's why it's so important when everybody's seeing people in the emergency room or in their clinics, if they're seeing people with Medi-Cal, you're asking, well, what county are you in? Because that's going to determine where you're eligible for services. Because again, it's a managed care plan centered in the counties. So the idea was to improve service quality and oversight. So the counties are responsible for overseeing the quality of services that are provided throughout the network. And it's all based on the ASAM levels of care. So it's all, if you opt in as a county to provide the organized delivery system model, you are agreeing to provide all levels of the ASAM continuum. So here they are, for everywhere from early intervention, which is really kind of like educational upstream work, through outpatient services, intensive outpatient, partial hospital. Then you start getting into the residential services, where you've got 3.1, 3.3, 3.5, and 3.7. I'm not going to talk about the differences between them. That's a whole nother talk in and of itself, but those are residential programs. You have to provide all of those levels of care. And then at the other end of the spectrum is the 4, which is basically acute hospitalization. So that doesn't technically need to be covered by the counties, because remember, hospitals are managed by the managed care plans, the Medicaid managed care plans. So you're, as a county, if you're an ODS county, you have to provide all these levels of care. Now I'll add a practical caveat to this, which is 3.7. As far as I know, there are maybe 2 of them in the state. So it's hard to have a 3.7 if there's only a couple of them in the state to begin that are certified at 3.7. That's a hole in the system that'll need to get worked out in time. So when we talk about if you're talking about a client that's coming in and you're thinking about sort of where the money's coming from and how what is important to someone who is looking at the money in Medi-Cal. This is what you're looking for in terms of substance use services. You're looking at, number one, the type of service that's being provided. So I want to know, if I'm building my program in my county and I'm looking at different providers in my county and I'm saying, okay, well, who do I want to contract with? And I'm looking at this and I say, type of service. Well, there's residential and intensive outpatient service. The state general fund matches the federal. So again, this is where it gets a little wonky. And I know I told people that I'd try to keep it as close to earth as I can, but bear with me on this. So I'm sitting in the county and I'm at a meeting and the state is telling me, well, if you build an organized delivery system in your county, we will pay the match with the feds for residential treatment and for intensive outpatient services. So wait a minute, you'll pay the match. So what do I pay as the county? You don't pay anything, right? This is the interesting thing about this. So the county has to build it. The county has to claim for the services. But at the end of the day, when everything's reconciled, the match, the sort of the state contributes, the feds contribute, that runs back to the county. The county essentially doesn't have to pay or put up any of its own money for those services. And I know there are finance people that are much smarter than me, in this room likely that could pick this apart a little bit, but just trying to explain it in my own sort of dense way about this. But so you really want to know sort of like, what is the type of service that we're building? So if we're building a residential or intensive outpatient service, and I'm going to my county and saying, like, this is how much money you're going to need to give me to build this, I'm essentially saying, I'm going to get 100% of this back from the state. I'm going to get, and the state's going to get some match of this from the feds. And then other services, though, like outpatient services, for example, those the county has to put up their own money. And where does that money come from? Well, that money potentially comes from the realignment dollars that I mentioned before, probation money through AB 109 if it's a probationer, and AB 109 was also built into the 2011 realignment. The second thing that you really want to know, so number one, you want to know the type of service. Number two, you want to know the aid code. This is Medi-Cal language, Medicaid language. Again, many of you will forget this immediately after this talk, and that's fine, but some of you might hear this again. The aid code. So if I'm newly eligible from the ACA, if I fall into that category where I'm under 138% of the federal poverty limit, and I'm new, so that makes me newly eligible for the ACA, courtesy of the ACA. The feds are actually going to match about 90% of my expenditures. So all I have to do as the county is I just have to get the claims up to the state, and the state's not even going to have to put much forward. They're just going to have to put 10% forward. This is all the new people under the ACA. So this is how a state accesses a lot of federal money, if this is making any sense to people, is that you are looking for opportunities as a state where you can maximize what the feds are giving you. The ACA is saying, if you bring in new people under the new rules under the ACA, we'll pay almost everything for them. You build the system, we'll give you money. Okay, so if you happen to be part of the old mandated population before the ACA expansion, then the split's 50-50. So again, this was what the ACA did to kind of incentivize states to do the expansion in the first place, because they said, listen, we'll increase our match. We'll increase our match. For the first few years, it was 100%. Now it's moved down to 90%. Okay. So let's talk about, and I know I'm running out of time, but I want to talk about what about people on either end of the age spectrum. So you've got old people and young people. So old people, say old people, 65 plus is hardly old, but for people over 65, I'll take the judgment call out of that. But for people over 65 who are Medicare eligible, once you hit 65, you're out of Medicaid, unless you're what we call a dual or a Medi-Medi, where you have been on Medicaid and you continue to be on Medicare. But generally, once you hit 65, you are up, you're Medicare's responsibility. And Medicare has its own provider lists, it has its own services. They're pretty abysmal, as you know, when it comes to delivery of services for people over the age of 65. It doesn't reimburse very well, so a lot of providers don't accept Medicare. If you're on the other end of the spectrum and you're under 18, then you fall under what's called EPSDT, which is early periodic screening, diagnosis, and treatment. The rules, if you're under 18, are much broader for your eligibility to pull down Medicaid dollars. That's been built into the law so that kids have, there's an opportunity to get kids into treatment. The match for kids when it comes to a county, again, it's tied to the county. If the kid lives in Marin County, this is sort of like what it's going to, what you're going to be eligible for in Marin County. And these are the services that we have. And those services, the match for those services, the funding is going to be coming from these realignment dollars, basically, or county general fund. If you can find the services, as many of you also know, if you work with kids, there aren't a lot of services for kids. When you try to find a residential substance use treatment program for kids, there's only a few of them in the state, and they're really hard to find. And if you live in Del Norte County, and the closest one is in LA, it's not all that convenient, because there just aren't that many programs. So this is, I'm going to glance over this one pretty briefly. This is eligibility for, as an individual, what do you need to have in your county to be eligible for drug Medi-Cal organized delivery system? The main thing here really is to emphasize this idea that you have to live in a county participating in ODS. You become part of that county's managed care plan for substance use by virtue of your address where you live. That's why people seeking services in San Francisco or from Marin County may not be able to get services in San Francisco, because those services may not be contracted with Marin County's managed care for substance use. This slide, again, it took me a little while to put this one together, but the basic gist was to kind of then say, to kind of get us to the point of then looking at the holes in the system. So we've talked here about sort of substance use services that are provided by the ODS system. And we've got, that's sort of this arm kind of coming out to the upper right, where it's county SUD systems of care, the ASAM continuum, the provision of all these services. But that's not where everybody accesses services. Some people access substance use services at emergency departments or hospitals. Those are really going to get paid for, through, those are really going to get paid for by the medical managed care plans, the partnership health plans, not the counties. You've got your primary care clinics, also going to be really much more paid for by the health plans, not necessarily by the counties. It's not part of ODS. It's not an ODS service to provide substance use counseling in an FQHC. I'll skip over medications for a second. Telehealth, this one gets a little bit complicated, but the basic gist is that with telehealth, because there are a lot of these freestanding telehealth companies now that are providing services for Medicaid individuals, they basically get their payments through the health plans as well. So again, it's back to that, like the health plans have a lot of footprint on the substance use system, even though they're not part of the ODS system. Harm reduction programs are kind of left out of the whole thing. Most of their funding comes from, philanthropic donations, or if they happen to have a contract with the county for a particular service. And then finally, jails and prisons. I think it's really important to emphasize here that Medicaid stops paying when you go into custody. So it's a huge hole. There are many people who've past several years have been trying to kind of close this, and there's some movement potentially, but once you go into jail, you're now the responsibility financially of basically the county's general fund. So local tax dollars is paying for your treatment services when you're in custody. Medications, I'll just add this as a final caveat. The long history of who pays for the meds. Right now, Medicaid beneficiaries, Medi-Cal beneficiaries in California get their medications paid for directly through the state through what's now called Medi-Cal RX. There used to be, some people took this, some people paid for that, some people paid for that. It's now kind of all centralized through one entry point through the state. By and large, that's been the case. So when you prescribe buprenorphine, when you prescribe naltrexone, and the patient gets that from the pharmacy, that's actually getting billed not to the health plan, not to the county, that's getting billed to the state directly through the state's pharmacy Medi-Cal RX program. Okay, this is a slide that's basically just reiterating everything that I just said in terms of the where some of the money comes from and where the gaps are. So like in the jails, for example, you're basically getting your funding for the services being provided in the jail from your local tax base, as opposed to being able to pull down Medicaid dollars for the exact same service. So somebody who's receiving substance use services then gets arrested and incarcerated. They can't continue to necessarily get those same services while they're incarcerated because the Medi-Cal stops when you walk through the door, and you're just at the mercy of what that jail happens to provide, or what that what they happen to be providing in that jail. Jails have gotten a lot better, but there's still a lot of work. Okay, so let me change gears here, and let's just talk about okay, well, what's been the impact? So let's just take a look at Marin and kind of say, okay, talked a lot about sort of like organized delivery system, what it is, where the money comes from, how it relates to Medicaid. And let's look at it here and say, well, what's actually been the outcome? Like, what's the boots on the ground? How's this looked in Marin County? So here's just a high level overview. In Marin County, we went live. We were the third county in California to go live with the organized delivery system. We went live April 1st, 2017. It was supposed to expire, but there was an extension through December 31st of 21. Now there's talk of kind of looping and lumping the organized delivery system in with another state initiative called Cal-AIM. That's probably 3 grand rounds worth of material right there. But Cal-AIM is going to be another framework in which Medicaid services are going to be provided. And there's a lot of payment reform that has gone into, or is proposed to go into Cal-AIM. Nobody really knows the full story on Cal-AIM yet, but because it's still evolving. But nonetheless, so take Cal-AIM out of it for a minute and just talk about, well, what have we seen so far in Marin County? Well, we've seen that we have had, well, I mean, before I get into that, I forgot that I had juxtaposed these 2 different slides here, but with this one, these were the goals of the drug Medi-Cal ODS renewal as it becomes available here at the end of December 21, and now getting rolled into Medi-Cal, kind of being extended into this Cal-AIM period. But we want to remove residential treatment limits. We want to get rid of that as in our next phase of the program. We want to get further policy clarifications on how do you access what's called recovery services. These are sort of sometimes peer-driven or peer-provided services that aim to kind of support people who don't need a higher level of care. They've kind of graduated, so to speak, and they're doing well, but they still need some supports. Recovery services really is aimed to kind of provide support for that. We'd love to expand medications for addiction treatment medications on the and get more of them on the ODS formulary, especially at narcotic treatment programs. We want to enhance access for American Indians and Alaska Natives. We want to expand the menu of evidence-based practices, such as like contingency management. These are all goals for kind of the next round of ODS. Now, so what does it look like in Marin? So here we go. So we have 30,000 foot view of the good things that have come out of the ODS system in its first, roughly 5 years of existence. So we have an increase in clients accessing drug Medi-Cal services. We had a 114% increase in unique beneficiaries accessing Medi-Cal services from 2015 relative to 2019, 2020. We have an increase in drug Medi-Cal revenues for substance use services. So 258% increase in Medi-Cal revenues. In other words, we're accessing that money from the state and the federal government that we're drawing down that money based on services that we're providing. So that's an increase in Medi-Cal revenues. So the state or the county is pulling in more. There's an increase in the number of drug Medi-Cal providers. We had a 40% increase in substance use treatment sites and a 500% increase in drug Medi-Cal certified SUD treatment sites from calendar year 2015 to 2020. So SUD treatment sites versus drug Medi-Cal certified SUD treatment sites. The difference there is that one is drug. We've had an increase in overall substance use treatment sites in the county, but then we've had a real increase from what we had before in terms of how many of them are actually getting drug Medi-Cal certified. So in other words, buying in and saying, yeah, we want part of this program too. We want to provide services for your Medi-Cal beneficiaries in your county. So we've had a lot of increase in access to medications for addiction treatment, and we've had a lot of service engagement. We've had a higher average length of stay than the state average. So in other words, we have more providers and more people are staying in for longer, which again, the research suggests that the longer you keep people kind of attached to services, the better they do when it comes to substance use treatment. Okay. My final couple slides here, just comparing this with what we call the regional model with Partnership Health Plan. So a number of counties, you can see these: Humboldt, Lassen, Mendocino, Modoc, Shasta, Siskiyou, and Solano, all wanted in on the organized delivery system program, but they're smaller counties. They didn't want to do it on their own. So Partnership stepped in and is actually, we're functioning as we're functioning as a county for those counties for the purpose of provision of substance use services. So created a system that's sort of over these 7 different counties, contracted with all the providers, moved people from county to county to access different services. We went live with this in July 1st of 2020, so mid-pandemic. And this is just some of the snapshots of data that have impacted or that we've been able to look at in terms of partnership data. So we've got, you can see the number of people served and kind of the breakdown in terms of ethnicity. The partnership network, is primarily, in areas that have historically been more Caucasian white. So that's, and the numbers kind of reflect that, those demographics. About 30% of the clients are who are entering treatment through our program in these 7 counties are experiencing housing instability. Again, that's not surprising. That's pretty consistent across the state. 65% are unemployed. 66 are self-referred, meaning they're self-referred. They referred themselves in. And we have about 33% of clients leaving prior to treatment being completed, typically on the residential side. Again, not atypical when it comes to most residential treatment programming. So, and this pie chart over here, obviously the numbers did not come out in any way that anybody could read this or decipher this, so I apologize for that. But it's basically showing again, this is the different demographics and the different sections of folks and how they're being served. So here are some additional impacts from the partnership model as of kind of since we opened it up on July 1st in 2020. And this is the thing about the health plan, and this is where, again, people's heads are spinning, I'm sure, about this, all of this, but let me just, if you can understand this piece of it, then then much of the rest sort of hopefully will come into focus, which is the health plan is responsible for primarily and originally is responsible for the provision of medical services to Medi-Cal beneficiaries in their network. That's what the health plan, the managed care plan, is originally designed to do. So the health plan takes on additional substance use services through this regional model, through developing its own ODS system. So it's important to remember that, like, and this is potentially the model of the future, is that now you've got the health plan actually managing both the substance use benefit and the medical benefit, and understanding that on the medical side of the house, people are still accessing substance use treatment through primary care doctors, through hospitals, through emergency departments. So again, it offers an opportunity for looking at this and saying, well, where does the money, who's paying for the different parts, and is there anyone that's able to look over all the different parts? And in most of the systems in the state, what we see is we've got a county overseeing their substance use programming and their specialty mental health, and then there's a health plan that's completely separate that's overseeing the medical benefit. Same patients, two different systems, not a lot of cross-pollination for the most part. So the model that we're trying to pilot here with the partnership program is like, what if the health plan takes in the part that, because the counties have not been, like in these counties, they're small counties, they haven't had the administrative support to be able to kind of construct an ODS system on their own. How can we kind of bring that into the health plan and offer an opportunity there? And will that enhance the provision of services, because the health plan can see everything from the medical side through to the substance use treatment side. Okay, so in summary, Medicaid is complicated. Okay, so that's the best summary I could make if you've hung with me through today. But here for folks, I think the slides are, folks, I certainly don't have a problem sharing my slides, and you have access to this afterwards. And also feel free to contact me if you want to hear me ramble on more and more about random parts of our Medicaid system. But here's just some bullet points about what I've tried to get across today, and an appreciation in particular for the ACA and for the opportunities that the ACA created for treating and having more people have access to Medicaid benefits, in conjunction with the expansion of this ODS system starting about 5-6 years ago, and how that's revolutionized the delivery of services. And it's important to understand that revolution only happens when you follow the money and you understand how the incentives work and why it would be financially beneficial for a county, not just of their own goodwill to kind of expand Medicaid services for substance use, but also to be able to look at that and say, I can do this, and I can get, I don't have to spend a lot of my money to do it. And I'll close with Alex Briscoe. If you've ever had a chance to listen to him talk, he's over in the East Bay. He was working with Alameda County for a long time. Really respect a lot. There's a lot of YouTube videos and things of him talking and explaining sort of Medi-Cal and Medicaid. And he likes to talk about this notion of you got to hustle. If the money is available at the federal level and it's sitting there, you have to find a way to hustle to get that money, because that's free money if you can get access to it. And that's what the ACA really kind of set the stage for us, and what the organized delivery system is really trying to take advantage of. So with that, I know I rambled all over the place in a topic that's incredibly boring for most people. But I'm happy to, I really don't know the timing. I assume I've gone over because I always do, but.
Well, Jeff, thanks so much for this. And we are over. If you want to hang on for a few minutes, and anyone else who has any questions, we can certainly do that.
Sure.
But those who need to go on to other things, please. Thank you for joining us today. There was a question in the chat, and I'll just read it, which is none of the payments wait, let's see. The question is whether the payments for residential treatment comes from the county, or just from the state and feds. So in other words, is residential treatment just being funded through Medicaid from state and federal and nothing from county? Is that the case?
That is the case now. Whether the state changes that in the future, who knows? But right now, basically, that's the residential treatment is so the county has to administer the provision of the service. So there is a, there is a cost associated with providing the service, right? Like having the administrator there, having the quality control people that are providing the oversight and monitoring the contracts and things like that. There's a certain amount of administrative cost that goes into having a residential provider on contract. However, when the individual gets treatment at the residential provider, that residential provider is now billing the county because the county is the contract holder. But the county is then making sure that all the ducks are in a row, that it's a claimable and that it meets medical necessity, and that the claim is going to be reimbursed. And then the county pays the county will then pay the provider. Now, in the meantime, what's happening though is that the county is also submitting that claim up to the pot of money and saying, give us what we're owed for the provision of this service. So the county is then drawing down something from the state that's matched by the feds, and is then siphoning that money back to the provider. So the money that actually goes into the pocket of the provider for the provision of the service actually is not county money. That's state and federal money that's paying for that service. However, again, to get that, there are people involved, and those costs are not necessarily 100%, covered by the state or by the feds. So again, there's that piece of it, a small piece of it, that's sort of like the administrative cost of holding the contract, monitoring the contract, collecting the claims, bringing the claims up to the state, adjudicating the claims, bringing them back down, and paying out the provider through that. So there's this, the county really does function as the middle person in that conversation.
Okay, well, we have a couple others, and we can just take a few more minutes. I think this question is, what are specific programs that Medi-Cal pays in terms of PHP and IOP for drug and alcohol treatment? Do you have any examples of Bay Area programs?
Yeah, so the easiest answer to that, and I mean, there's no easy answer to this, these questions, but the easiest answer to that is that each county is mandated, if they're an ODS county, each county is mandated to contract for all of the levels of care. Now, they're also mandated to post those contracts and post sort of like what those treatment services are. This is where it gets tricky. Like, I can point you to where that's posted in Marin County on our behavioral health website, but I can't really point you to that. I wouldn't know where to start with Monterey County, for example. Like, I would be Googling and trying to get into their website, but the thing that I'd be looking for would be, in Monterey County behavioral health, who are your contracted substance use providers and what levels of care are they providing? So in Marin County, for example, as part of our program, we developed a what we call Road to Recovery program. And that's just the title that we gave it. But that program is designed really to serve co-occurring, serious mental illness and substance use individuals with substance use issues. So that program, again, very, very limited. You have to be part of the county's mental health program, the serious mental health program, and you have to have an active substance use issue. You get referred into the Road to Recovery program. And in that program, we offer recovery services for people that have gotten, improved to the point that they just need some occasional support. We've got recovery services, we've got outpatient services, we've got intensive outpatient services. We don't have a PHP with that one, but we do have the intensive outpatient services. And again, that's an example of sort of that's our program that we developed in the county, but we also contract with some other providers that provide intensive outpatient programming and partial hospital programming. Um, and I could, again, I could kind of talk through the Marin ones, but um, if you wanted to know San Francisco's, for example, and I haven't looked at San Francisco's list for a long time, I could make some guesses about who probably offers IOP or PHP, but I'd be going to the website looking for their posting of sort of who they're contracted with and what services they're provided.
Well, thank you. And Valerie Gruber shared that San Francisco County ODS does not have PHP level of care. So thanks, Valerie. I think one last question. Do you have examples of what interventions led to retaining individuals in treatment longer?
Well, I guess I've got I'll ask a follow-up question. I don't know who asked that, if they're still even on here, but like I guess it depends. First thing would be, it sort of depends on which service, like which level of care. Like if we're talking about like residential level of care, I think there are a series of things that kind of make that, make that the retention and treatment work better. One would be, and again, this has to do with, again, that when the organized delivery system came into play, one of the things that the sort of unintended consequences of that, or I guess it was actually an intended consequence of that, was a recognition that prior to the organized delivery system, there was no centralized way of monitoring quality of care that was provided. It was very shotgun approach. There was a lot of different providers, and it was very hard to get a grasp on sort of what the quality of care was that was being provided across these different providers. So the organized delivery system basically, as a caveat, mandated that the county has to monitor the quality of care. So I think one thing that improves the retention and treatment is you're providing better treatment because there's better oversight. Now I can't say that that's totally always the case, like, more oversight means better care. But I think relative to where it was before the ODS, that additional quality monitoring and auditing that goes into it, and the expectation and the knowledge that you as a treatment provider are going to be expected to, attest to the quality of care that you're providing, I think that increases, the quality of care. I think another thing is that the idea that you have, by increasing the number of different residential providers that you have available, because now again, if you're not having to outlay a lot of county general fund to pay for these services, you can now contract with a lot more places. As you all are probably well familiar, different residential programs have different strengths, and they have different weaknesses. Different residential programs are more 12-step, some are less 12-step. Some are, male only, some are female only, some are transgender, some, have different expertises, different niches that they can operate better with. And as a result, if you can match the type of residential program, even though they might be the same level of care, like you've got treatment provider A that's providing a 3.3, and you've got treatment provider B that's providing a 3.3, technically the same level of care, but very different culture of the place. You can better match patients with a residential treatment program that might better serve their philosophical needs or their spiritual needs or whatever their significant needs might be. So I think that's another thing that's helped with kind of retention in treatment. And I think also the other thing that's probably helped with retention and treatment is that it's for residential, at least, it's less cumbersome than it had been before, where before you had to pay for residential services through these block grants, primarily if you were going to offer it at all, before the ODS. But now with the ODS and with the advent of sort of residential being an actual covered benefit, the sort of piecemeal and onerous process of kind of trying to get money to pay for residential has become more straightforward. Now, some might argue you've added additional layers of bureaucracy, which make it that much more complicated. But I think, in general, when you divorce it from the block grant process and say we can pay for residential just through this pathway, every county goes through the same pathway, that pathway starts to be a lot easier to manage and a lot more universal than sort of each county with their block grants.
Okay, well, gosh, thank you so much for answering all those questions. An excellent presentation, Jeff. As I think Dr. Devido mentioned a moment ago, feel free to reach out to him directly if you have some follow-up questions, and certainly usually within a few days, we'll get these this presentation uploaded to the public website. So that'll be available for replay. And I think the slides will be downloadable from there as well. So with that, everyone have a very good afternoon, and thank you for participating today.